So thank you. Thank you for everyone joining us tonight in the audience, as well as those listening in from home. So as a medical oncologist, much like Dr. Hanks, my focus is on drug therapy for patients with more advanced stages of melanoma. So switching gears a little bit from immune therapy, I'm going to talk about what does having a mutation mean in the context of some of the newer agents and targeted therapy for melanoma. There we go. So 2010, this is actually when I started my career at Duke. And so a lot has certainly changed in the treatment landscape since that time. And I like to think in a similar way in terms of some of the evolution of drug therapies for melanoma, which you've heard a little bit about. So pre-2011, we really didn't have very many agents. And around that time, we saw the approval of vemurafenib, so a targeted agent, which we'll be talking about, and of course, immune therapy with ipilimumab. Just a few years later, we saw an additional BRAF inhibitor as well as a MEK inhibitor, so targeting another gene in 2013. We then saw combination therapy. We then saw the approval of PD-1 agents, pembrolizumab and nivolumab. We then saw, I think you'll see a theme here of starting to combine things, so Nivo and Ipi, TVEC, which is a slightly different type of therapy, but injected directly into lesions, so a modified herpes virus. We've now seen some of the immune therapies moved into different disease settings. So instead of just treating melanoma that can't be removed surgically, we're now starting to use some of these newer agents to try to prevent melanoma from coming back after surgery. And the medical term for that is adjuvant therapy. I just think of it as preventative therapy. So we now have adjuvant ipilimumab. We now have a second combination targeted therapy, so cobimetinib and vemurafenib. And then I just added this in as of probably about 3 weeks ago. While not yet FDA approved, we've seen some promising data using preventative nivolumab, so preventative PD-1 therapy after surgery, as well as combination therapy. So my focus and all of that and all of those advances is going to be talking about genes and the targeted therapy in melanoma. So there are different types of genes. I think it's important to understand what a mutation is and what that means in the context of melanoma. I'm going to focus on a few genes in melanoma tonight, primarily on BRAF, not because it's the only gene in melanoma, but because it's an important gene in about half of patients with melanoma that's believed to be important in driving cancer growth. We also now have therapies that can target it. And talk a little bit about targeted therapy and how is it different from some of the traditional chemotherapies, as well as review some of the common side effects. So pardon the artwork, but this is sort of my genetics 101, so all about genes. So genes really start with DNA, and I think of DNA as like a roadmap for instructions, or so to speak, on how to build parts of the body or parts of things that need to be created. And so DNA exists as this kind of roadmap. These are sort of these base pairs here that then get wound into a larger structure. I don't know if you can, it's a small pointer, a larger structure called chromosomes. And then chromosomes live within the inside of your cells. And then so how do we translate those genes, that roadmap, into proteins that are actually doing the work that we need them to do? So we start with DNA. So I think of the DNA as like the plans, if we're thinking about construction. And I think an important medical terminology, so a normal copy of a gene is called wild type. And so I once had a nurse tell me, oh, I thought wild type meant that the gene is not working properly and that it's just going crazy. But what it actually means is that it's the most common variant that's seen sort of in the native population, so the most common copy of a gene. So that's what wild type means if you ever see that in any sort of medical reports. It means it's a normal copy of the gene. Those roadmap plans get changed into proteins and translated into proteins. First, into smaller proteins that are then folded into larger protein structures. And I think of those as the building blocks, sort of this doing the jobs that need to be done, with the finished product being whatever the creature is, so you in this case. What happens with mutations is that there can be a change in those plans, so an alteration in that roadmap, which I kind of demonstrated here, that then something goes wrong here, that then alters the way the protein gets built, which has the potential to transform into cancer. I think it's important to note that most mutations don't cause cancer. Your body has evolved many systems to actually fix some of these changes, and it really depends on where the gene is and what type of gene it is, whether it ultimately forms into a cancer. So then when we think about genes, I like to think about different types of genes. And I think what we most commonly think about are inherited genes, so traits that we may inherit from our parents, be it curly hair or blue eyes. And that often comes to mind. When we talk about cancer, we're really talking about two different types of genes. So it is true that families can carry genes that are passed down that increase risk for cancer. Probably one of the most common examples of that, or that's well known, is with some rare forms of inherited breast cancer, for example. But that's actually the minority of cancer-related mutations and cancer-related genes. So this is an example of inherited gene, where the mother here has a copy, an altered copy of a gene, and that's passed on to the daughter. And so this altered gene mutation is called an inherited or germline mutation, so the kind that's inherited or passed down through families. But what we're really talking about here, and in the majority of cancers, is that cancers can have their own genes. So these are genes that are not inherited or passed on. These are genes that can be altered within the normal cells of your own body and form a cancer. And we call those acquired or somatic mutations. And the way we test these in cancer is by analyzing a piece of tissue in the lab and are able to tell whether certain tumors have certain genes. So when I think about genes and pathways in cancer, and when maybe a physician gives a talk about this to another group of physicians, it's common for a pathway map like this to get put up, and you can kind of see eyes glaze over, trying to kind of connect all the arrows, and my head is hurting by the end of it, because it really is, it's very complex. But I prefer in the clinic to talk about this sort of in a different way, where I think it makes a little more sense, and maybe doesn't require a PhD in molecular biology. So I think of genes and pathways as like a string of dominoes. So using BRAF as an example, our body has evolved systems to transmit signals from outside the cell to inside of the cell. So you can imagine, remember the chromosomes living inside the cell, they need to get a signal somehow. So I think about them getting a growth signal from outside the cell, and that each domino in the chain has to be triggered to cause a reaction in the next domino in the chain, ultimately leading to increased growth, and it's tightly regulated. So I just think of BRAF as one domino in that chain. So if we move that to cancer and how that works with BRAF-targeted agents in melanoma, we think about outside the cell. I put in a domino here, so you've got your signal that has to trigger, and the names here aren't as important, but there's a chain of proteins that has to signal, and with the next one on down the line, to get the ultimate effect of increased cell growth. And this is one of the pathways that cells, normal cells and cancer cells, use to regulate growth. So this is BRAF wild type. So this is how the normal BRAF is supposed to work. What happens when BRAF becomes altered, and that protein structure becomes altered, it's named here position 600, because that's just the number of the protein that becomes altered. This abnormal BRAF is able to activate the downstream dominoes without any of these other signals. So it becomes uncoupled and unregulated, and that's one of the hallmarks of cancer. This was discovered several years ago, actually, and then tested in a series of clinical trials. So I'm summarizing about 15 years of work in this one slide. But we realize now that there are targeted agents that can essentially shut this overactive gene off, and dabrafenib and vemurafenib. It's made a little bit easier because at least there's RAF in the name. I know the names get long. And we also have now figured out that shutting down the next domino in the chain has led to improved outcomes as well. So that's with trametinib and cobimetinib. So the next domino in that chain is MEK. And this is an example of what this looks like in patients. So this is BRAF targeted therapy in a patient with metastatic melanoma. And you'll look here at the slide here on the right here. And this is a CAT scan. And then the lungs normally are supposed to be filled with air, and that appears as a dark field on a scan. And so these round spots here are all tumors. And so this is what the scan looked like before we started any therapy. And this is the scan that you see here after 6 weeks on therapy. So shutting that light switch off, the tumor had an activating mutation in BRAF. Shutting that domino off essentially was able to shrink the tumors in this case. And this is what we first discovered in terms of looking at BRAF targeting therapy alone in melanoma, so just using one drug at a time. And it's a lot of numbers, and I think it's not necessarily important to kind of look at each study. This kind of summarizes the early phase studies all the way to the bigger, larger, what we call phase 3 trials, but essentially showed that it shrunk tumors in about half of patients. So this is with both agents, either vemurafenib or dabrafenib. But it did show that at some point, usually the tumors figured a way to sort of outsmart the drug. And the average for that was kind of around that seven-month range. That doesn't mean 7 months exactly for every patient. That just means that's what we call a median. So half of patients have progressed before then, half of patients may still be on therapy. So this, again, another slide looking at the combination. So it was figured out one of the ways in which tumor cells figure a way to outsmart the one drug could be overcome by blocking the two proteins at the same time, so BRAF and MEK. And so these trials essentially combined BRAF and MEK inhibitors and compared them to just the one BRAF inhibitor alone. And what they showed was a benefit in terms of increased response rates. So it improved response rates from kind of in the 50s, kind of up to the high 60, in some cases close to 70%. And it extended the time that patients benefited. So patients appeared to have control of their tumors for longer on the combination therapy. But you'll note, and this is a little bit different than immune therapy, that while some patients can have long-term benefit, we still feel that most patients, these don't represent a cure. While they represent very good treatments, most patients' cancers unfortunately ends up growing despite good targeted therapy. I think it's really important to talk about side effects, and these are just selected side effects for different agents, and I tried to kind of pick out the ones that I find sort of bother patients the most and sort of contrast how the two BRAF and MEK inhibitor combinations that we have, dabrafenib and trametinib versus vemurafenib and cobimetinib, differ. So the first part about targeted therapy is that it targets a gene, and while we wish it only affected the cancer, there's certainly what we call off-target effects or other effects as well, and that's where we feel like the side effects come from. So targeted therapy doesn't mean that there are no side effects, and I think this highlights this here up at the top. So the majority of patients on trial had some type of side effect. When we grade side effects, we often grade them on a scale of 1 to 4. The higher the number, the more severe it is. And so looking, usually a grade 3 and above is considered severe. So about a third of patients had severe side effects. I'll say probably the biggest side effect that is bothersome for patients on the dabrafenib and trametinib combo are fevers. So half of patients on the combination, you can see that much higher, almost double the number on single agent, get fevers. This is where our grading system sort of fails when we think of only grade 3 as being severe, because a grade 2 fever is 104 degrees. So most people feel pretty bad with that. The good news is that just stopping the drugs can often fix this for patients. And I can't stress enough, along with what Dr. Hanks was saying, that early call to providers to talk about what's going on and making decisions about stopping drugs. Sometimes we can restart drug at the same dose. Sometimes we can reduce the dose. But because you get a fever doesn't mean that you can't get targeted therapy anymore. Skin lesions, this is due to some of the effects that these drugs can have in cells that have a normal copy of BRAF, or is actually improved on the combination, so we see less of that. So some of these skin lesions look like warts, and in rare cases, things like squamous cell carcinomas. This is looking at the other combination, vemurafenib and cobimetinib. So we've talked about how they're similar in terms of their effectiveness, but their side effects do differ a little bit. Again, most patients have some side effect. This severe side effect listing is a little bit misleading because some of these are lab abnormalities that don't cause a lot of symptoms and aren't considered sort of clinically serious, but I just wanted to highlight that. Fevers are still an issue, but you'll notice it's a lot less. So the rate of fevers is about half that versus the DAB and the TRAM. Again, we saw the mitigation of the skin lesions on the combination. Fatigue is an issue, which is, I would say, the same between the two drugs. In my experience, it's the joint aches that tend to be a little bit more pronounced with this combination. Again, see it with single agent as well as the combination therapy. And then sun sensitivity, so having skin that's really sensitive to the sun to the point that folks can get burned just riding in a car, so severe burns, not just sunburn, can also be seen, and so that's a unique side effect of this combination. Other things to consider, both combinations can have effects on the heart and the eyes, although it's rare. Just some logistics in how they're taken. The DAB and the TRAM have to be taken on an empty stomach. And then trametinib must be refrigerated. So depending on patients' lifestyles, that is a consideration. Vem and Cobi can be taken with food. Cobi is taken 3 weeks on with 1 week off. So that's something to consider in terms of remembering, when it's time to kind of restart your next cycle. Resistance is still a problem. So unfortunately, this is a patient who had tumors. These yellow areas are tumors. They started therapy, and we can see a lot of those went away. But unfortunately, sort of by month 6, things started to come back. So I think we've made a lot of progress, but I think clinical trials in this area are really important and really needed. Very briefly at the end, I don't want to say that BRAF is the only story in melanoma. There are many genes that are important. It does account for about half of mutations here in the purple. The CSD is just chronic sun-damaged skin. But the other 2 mutations that can be important are KIT and NRAS. NRAS is in about 25% of melanomas. KIT is much rarer and often seen in these uncommon or less common subtypes of melanoma that occur on palms and soles or sometimes mucosal melanomas. This is an example just of imatinib, which is a drug currently approved for a rare form of leukemia and some other cancers that can target KIT as well and can be used in patients who have these mutations. I mentioned this not because it's approved, but this is the NEMO trial in which patients with NRAS mutated melanoma were randomized to receive a MEK inhibitor, and there was shown some modest benefit there, although not quite the benefit that we've seen with some of the other targeted therapy like BRAF. So this is sort of my conclusion slide. So I think certainly the message is progress. We really have more treatment options than ever before. Targeted therapy, it doesn't mean that there are not any side effects, it's just unique side effects, and I think your doctor needs to be familiar with these. We're still learning about the best combinations and sequences of therapy, and I think I always encourage folks to consider a clinical trial. It takes a melanoma team, so I'm happy to be here with all of my colleagues, a multidisciplinary team, and then certainly, first and foremost, our patients and our families that we work with every day, my clinical team and research team as well. So thank you all very much.